Another is peritonitis. If she develops peritonitis, then tender lower abdomen, digit like this. And if you do vaginal examination, mostly need to differentiate from the uterine tumor. As it is adnexal structure, so there is a gap in between the ovarian tumor and the uterus. You understand? As it is adnexal structure, not attached to the uterus. So there is a gap in between uterus and ovary. Can you understand? There is a gap in between ovary and that is ovarian tumor and the uterus. That is so. If there is uterine growth, any gap in between them, if you suppose the only uterine growth, there is no gap. There is no gap in between this. If it is uterine growth, there is no cleavage line, no gap is found in the tumor with the other structure. Okay? And mobility, if it is uterine origin, ovarian tumor is easily mobile, usually. But if it is uterine growth, you can able to mobile or not possible. Yes, very good. But if large subserous fibroid, if you know the uterine growth, there is serous, that is subserous, interstitial and submucosal. So if it is subserous, there is some movement possible, but most time it is interstitial. That is from the muscle of the uterus, so movement not possible. Can you follow me today? I don't know, fasting, all are fasting, it's a problem during fasting. So one of the important things, again I want to say, ovarian tumor is epithelial origin. Epithelial means serous, what I wrote, serous, mucinous, Brenner's, transitional cell tumor, Brenner's. So I think you know from the pathological class. So another most important is from the sex cord, that is germ cell tumor, most important. That is more common, germ cell tumor. Most tumor is dysgerminoma, teratoma, sex cord, stromal tumor, erhenoblastoma. You should remember from your pathological class, what are this type. So the dysgerminoma is most common, teratoma is most common. Teratoma in the malignant benign form, what is the common tumor? Dermoid, very good. Who told? Very good. You saw, dermoid. Dermoid cyst is the most common. Middle age group, dermoid. What is the interesting of the dermoid tumor? As it is totipotential germ cell, so all three layer germ, all three germ layer derivatives are found. From epidermis, all the derivatives of the epidermis like tooth, hair, skin structure, bones. Bones is mesodermal. Then mesodermal. Mesodermal origin is blood vessel cartilage. These are the most common findings. And endodermal is GI tract, gastrointestinal tissue. Gastrointestinal tissue is common. So dermoid cyst, one of the common germ cell tumor, and this is so important. So clinical features actually depend upon the pathological lesion and the complication. Otherwise, as you know, all times the ovarian tumor patient comes in late to us, as complication is so less. And malignant ovarian tumor patient always come to us third stage, fourth stage, due to no complaint, no problem. They cannot notice any problem. So what should we know? We allow for the late stage for diagnosis, or we should prevent. So for the prevention, what are the type of prevention? Primary prevention, secondary prevention and tertiary. What is primary prevention? Education and vaccination like this. Secondary prevention is screening. I told today, what I told today? Cervical cancer screening. I show you what I show. Pap smear, how it should be taken. So for screening is the secondary prevention. And tertiary prevention is earlier diagnosis along with the surgery. So the earlier surgery. So how can we diagnose the ovarian tumor screening? Is it a possibility as it is more internal organs? Tumor, yes, very good. Tumor marker. What are the others? By manual examination, annually by manual examination. And you say that tumor marker, and what are the others? Ultrasonography examination. If you saw ultrasonography annually, and the vascularity of the ovary, like this, so we can earlier diagnosis. Otherwise, tumor marker, but not always suggestive. So tumor markers, suppose CA125, more common, alpha fetoprotein, LDH, these are the common marker. And if you go to the investigation, so investigation, number one, you all ultrasonography of the pelvic organ, ultrasonography for pelvic organs, then CT scan, 3 MRI if needed, and from blood marker, tumor marker. Could you following the class or not? What I told? You can see me. Investigation. What are the investigation?
First of all, USG.
Ultrasonogram.
Ultrasonogram
Of the
pelvis. Then CT scan. After that, MRI and blood investigations for tumor marker.
Tumor marker, good. Okay, so after investigation, you confirm the diagnosis or you can suspect. You can pelvic tumor is always suspected. The origin, not most of the time cannot say the origin. So before operative procedure, we tell the term laparotomy. In ovarian tumor, always we use the term laparotomy, as we do not know exactly what is the origin of the structure. So after laparotomy, we plan and do the operation. What are the operation for the ovarian tumor usually? Ovarian cystectomy, and reconstruction of the ovary. Ovarian cystectomy and reconstruction. And another is oophorectomy, or tumor along with the ovary. In ovarian cystectomy, removal of the cyst and then reconstruction. So we keep the ovary. And that oophorectomy, there we remove the ovary along with the tumor. And another is sulfing oophorectomy. We remove the ovary along with the fallopian tube. Okay, now from the differential diagnosis, number 2 is uterine fibroid. If uterine fibroid, how can you differentiate from the ovarian tumor? There is, from history, there is a menstrual problem, mostly asymptomatic, but there may be menstrual problem. What are the type of the uterine fibroid? Interstitial, submucosal, Subserous. So which one causes more irregularities? Submucosal. Submucosal fibroid causes more irregularities of the tumor. As it is inside the uterine cavity, submucosal tumor is inside the uterine cavity. So it is causes abnormal spasm, abnormal lesion in the mucosa. So there is irregular bleeding, and it is painful. As submucous tumor always try to expel out. So there is painful, irregular, abnormal uterine bleeding in submucosal fibroid. So from history and then after examination and then investigation. So uterine fibroid and adenomyosis. What is adenomyosis? The ectopic endometrial tissue within the growth and development. You should use the two terms, growth and development of the endometrial tissue within the myometrium. And it is, can you understand, imagine what is the possibility of the complaint? It causes more pain, huh? more pain. And pain is characteristic. What is the characteristic of the pain? Start before, at the beginning of the means or at the end of the means?
Beginning of
No, it is not in the beginning. It is at the end. As you think, when means started, and gradually there is a collected in the where? Myometrium. So not in the beginning. At the end, more collection. So more, but it cannot come out. So there is more pain. So it is more pain. So severe dysmenorrhea in case of adenomyosis at the end of the menstrual cycle. Or what you told before starting of the means at the beginning of the means dysmenorrhea where? In case of pelvic inflammatory disease. Pelvic inflammatory, you know the PID? In PID at the start of the menstrual cycle or just before menstruation there is a pain. In case of pelvic inflammatory disease. Why? In pelvic inflammatory disease there is more congestion, increased vascularity, and more production of the painful substance. So it is painful just before the starting of the means. Okay, then what is the another differential diagnosis? Tubovarian mass. Tubovarian mass is a pelvic tumor, and what is the why it is happened? It is one of the complication of the pelvic inflammatory disease. In case of pelvic inflammatory disease, if it is causes salpingitis, and if it is untreated, ultimately it causes pus formation within the fallopian tube, the pyosalpinx. And tube is attached to the ovary, so tube and ovary mated together and form the tubovarian mass. Okay, so that is tubovarian mass, one of the complication of the pelvic inflammatory disease. So that is also one of the differential diagnosis of ovarian tumor. And hydrosalpinx then. Hydrosalpinx is one of the, what is this? Collection of watery substance in the fallopian tube. Sometimes it becomes so swollen. Can you imagine 16 weeks pregnancy size can develop in the ectopic pregnancy, can develop in the fallopian tube. So you can how much it is. So there is hydrosalpinx is make a pelvic tumor. And then what is another? Pelvic abscess. Why pelvic abscess? In case of septic abortion, there is perforation of the uterus or from the endomyometritis pus collected in the pouch of Douglas. What is pouch of Douglas? Okay. The space behind the uterus in front of the rectum. The pouch of Douglas. That is most descending part of the pelvic cavity, and the pus is collected in there. So that is one of the pelvic abscess is one of the differential diagnosis. Another appendicular lump. If it is the appendicular lump, also right-sided maybe, and pelvic appendix. How many percent is pelvic appendix? Can you remember? Not more, no? So if it is pelvic appendix form the appendicitis and and appendicular lump, then it may be also in differential diagnosis. And another is chronic ectopic pregnancy. And why it is if ectopic pregnancy unruptured or associated with incomplete tubal abortion and chronic clotted blood all together form the key adnexal mass, and it also comes in the differential diagnosis of the ovarian tumor. Okay, so this is the differential diagnosis, and we should exclude. What we should do? We should exclude from the from differential diagnosis the origin of the tumor, the nature of the tumor, and what would be the management by investigation and laparotomy also. And we should suspect from the history, from examination, from investigation. We must suspect before doing anything, before doing investigation, before doing procedure. If you do all investigation on patient for everything, so it would be, it should not be. Investigation should be limited, specific. So, any question from this up to this? Yes? Differential diagnosis? Repeat. E2 fibroid, adenomyosis. Okay, I think you know that one from there. Hydrosulfurous tube ovarian mass, appendicular lump, like this. So I think until today is the ending. Thank you. Percentage.